moment to.
Oh, well, thank you very much. For those who don't know me, I'm Ryan Mattick. I have the honour of being the president of the Craniofacial Society of Great Britain Ireland. And um, I'm delighted to be allowed to introduce tonight's seminar webinar on global cleft care. And I'm delighted it's the second set of webinars. The first, due to the enthusiasm of Cleft Bridging the Gap and Matt's great IT innovation, happened last year supporting Melanie's conference in Manchester. And I'm thrilled that everybody's been enthusiastic enough to do it again to help support in the run-up towards the Newcastle conference, which for those of you who don't know is on the 30th of April to the 2nd of May, and registration is still open. But tonight is the first of two webinars. The first one, this one, is looking at global cleft care and how we as a family, as Tim has just been discussing, can integrate a little bit more and work together more globally. And then there's another one, and I'm sure that there'll be a trailer for that at the end of the evening for later on in April, looking at research. So I'd like to welcome you all to not only the webinar, but also to hopefully the conference in Newcastle in 29 days' time. Thank you very much. Over to you, Tim, to introduce all your speakers.
Right, thank you very much. That's lovely, and it's great to have you here, and great to see everyone on screen, and really also grateful on a hot, sunny evening for you to devote a little bit of time to thinking about this, what we think is a very important matter, and that is how we best extend our friendship, our partnership, and working together across nations, and not just within the UK. We have great UK organisations, but many of us have had quite a lot of overseas experience. So we want to think about how to do it better. And many of you that are here that I can see have had a lot of global experience, but still always much to learn and much to learn about how to do things better. So what we're going to do, we're going to go through and have a series of about 6 presentations, so 6 speakers, and we don't expect necessarily to have slides. Some of the speakers will just talk to screen, I expect. But David has agreed to kick us off with some thoughts on his experience of an early adopter, in a way, of a link with Nepal, and we're really grateful to have his partner in Nepal, Shankar Rai, joining us. And we're grateful again. Thank you, Shankar. But it's very late for you. 6 hours, 6.5 hours at least, further into the night. So we're grateful to have you here, with eyes wide open, and that's great. So over to you, David, to kick us off. Thank you.
Okay.
I'm going to go mute myself so you don't get my call.
Thanks. I'll try and share that. Is that sharing okay?
Yeah, showing nicely.
It is indeed. Thanks very much, David. That's great.
Hi, everybody, and hi, Dr. Rai. Good to see you.
Hi, David.
So, yeah, thank you. I'll try and give my thoughts on the collaboration we've had with the team in Kirtipur Hospital in Kathmandu. This is sort of dubbed this sort of Newcastle Nepal link, but there's lots of other people from the UK involved in this as well. So it's not just a Newcastle Nepal link. So I went on my elective to Nepal in 2000, and I had a great time. I loved, the country and the people, but I guess I didn't really think much more about it until I became a trustee for Cleft in 2020, and we had sort of a discussion about maybe setting up a twinning relationship with a centre in another country. And I guess unfortunately there's lots of places around the world where you could twin, and so it's kind of almost an impossible task to choose a country. And since then we have set up some guidelines, which I think are really useful. But as part of that is a document that I think Brian had put together, which some questions that you might consider going through to find an appropriate twin. But I had emailed Dr. Rye uh, um, some years before, but never really for some reason or another, that really came to fruition. But I thought I'd email him again and just see whether he thought there might be any possibility of a twinning relationship. So I sent an email off, and I think within 24 hours he replied back saying yes, that would be excellent. So that kind of put the wheels in motion for an exploratory visit in 2022, and that was the advice that some of the senior people in Cleft had said. You know, if you think this is kind of something that you might like to take forward, then go on an exploratory visit. So I just went for a few days, met obviously Dr. Rye and the rest of the team, but immediately felt that this was something that, you know, we could be involved in. You know, the team were very friendly, humble, but clearly had very high standards and wanted to learn. And I just felt we could work together and mutually learn from one another. So since then, two of the local surgeons have come to visit us in the UK, Kamal in January 2023, and Pramila, who's the head of the Cleft service in Kirtipur Hospital. Pramila came in January 23 and Kamal came in September 2023. And then since then, we've had two MDT visits, one in 2023 and one earlier this year. We've tried to go with as many members of the MDT as we can. So from a nursing background, psychology background, Siobhan, who's got wide-standing links with Nepal and Kirtipur Hospital from a speech and language therapy background, orthodontics, anaesthetics, and surgeons as well. And then a slightly different makeup of the team for our latest visit. And Josh Kennedy came from a dental background. I think it's fair to say that probably the standard of dental hygiene and dental care in Nepal could be better, and obviously that influences lots of things like the ability to bone graft, orthodontics, and orthognathic surgery. So that was something that we were keen to collaborate on. So there's three main areas that we'd identified together that we thought we could help with. One was training, both in the UK and in Nepal, and not only for Cleft surgeons, but also wider members of the Cleft MDT. And I think it's fair to say that the standard of surgery in Kirtipur Hospital from a Cleft point of view is excellent. You know, they don't need us telling them how to do a palate repair or a lip repair. They're wonderful surgeons. But perhaps they don't do secondary surgery, so bone grafts, speech surgery, orthodontics or orthognathic surgery that we would be doing in the UK. And that's one area we've identified that we could collaborate on. Equipment and fundraising, so just simple surgical equipment, possibly an operating microscope, possibly a mini C-arm for palatal investigation, and then collaborating on research and audit. And so to fulfill those goals, we have monthly virtual meetings. I think that's really important to keep the relationships going, but also to discuss projects. We've had those two MDT visits and hopefully another visit next year. The two local surgeons have come over to visit us, and hopefully the lead Cleft nurse, Kabita, is planning to come over later this year. And we've also had a local Nepali surgeon be the Cleft Bridging the Gap Fellowship, and I'll talk a little bit more about that in a second. So these are some images from our trips. Lots of hands-on training from a surgical point of view. Siobhan doing lots of speech and language therapy training. One of the great things is that we managed to fund 14 nurses to come on both those visits we've had from an MDT point of view to Kathmandu, both for a week at a time. So they've had lots of teaching from Siobhan, Chris from a nursing point of view, and Kate from a psychology point of view. And to call them a nurse is a little disrespectful, because they almost do everything other than surgery. They're incredible nurses and very keen to learn. more operating here, and you can see Pramila's actually doing this. Was I think a revision cleft lip and a bone graft. She'd never done that as a combined procedure. Peter had talked her through the first case, and then she was doing the second case. So that was good to see. Here are the nurses with Kate, Josh, Mahadve, and Siobhan from some of the teaching sessions that they'd had. Lots of emphasis on dental care. And this is Bill Plesh, who's the Cleft Bridging the Gap Fellow. And what I think is amazing about this is a local trainee surgeon who's doing higher cleft care, trained by local surgeons, and the plan for him, I understand, Dr. Rise, that he's going to stay in Nepal and work in the peripheral units doing cleft care. So I think that really aligns with the ethos of Cleft in terms of teaching, training, and sustainable long-term cleft care. And then from an equipment point of view, just basic things like scalpel blades, mouth gags, toys, feeding bottles, sutures, other surgical equipment to do cleft palate repair, but also speech and language therapy resources. So this was some of the equipment that we've brought over before. Mahadve managed to get hold of 2 articulators, which I think the local team were delighted to have for planning orthodontic treatment. So that was excellent to bring those across. Mahadve managed to set up teaching with the local orthodontic team 30 bilateral cases during her week when she was in Nepal. And then from a research point of view, we're hopefully going to do a project on alveolar bone graft outcomes, speech outcomes, and some patient information leaflets. So I hope this is a good model. I'm sure there's lots of things we could do better, but I think the important things are going on that exploratory visit and finding a team that you feel that you can work with. It's been a real privilege to be involved, and I think we've learned just as much from the local team as hopefully we've been able to impart some knowledge to them. So it's been a real pleasure to be involved with the team from Kirtipur Hospital. And this is a photo from my last trip. I thought this thing about the Himalayas and Mount Everest was a hoax, but they do actually exist. I'd never seen them before, but on our last trip, the clouds cleared and we could see them. So it was brilliant to see them on our last trip. Thank you very much. I don't know if you want me to answer any questions now, Tim, or obviously I'll stay on and.
David, thank you. That's absolutely a super start, and lots of food for thought. I've got lots of notes and things I want to mention, and I'm sure others will have. I'm aware we have got others from your team online, but I'm also aware Imogen, who is going to talk about a slightly different perspective, traveling to the Philippines, can only stay till 6:30. So I was going to bring Imogen in and then switch, if that's all right. So, but if anybody has anything short for clarification from you, David, but otherwise, would you be able to be here after Imogen, just to join when Dr. Rise here? If you can stay on, that would be great. Yeah, okay, that's super. Imogen, can I maybe you can introduce yourself and perhaps just say a little bit about what's different about the link that you've been pursuing with Philippines, if I'm right. But can I hand over to you now? Thanks. Yeah, that's great.
Yeah, you can if I can unmute myself. Well, I've got a couple of slides. I don't know how different it is, and wasn't sure about the remit, so I've just literally done a few slides about in terms of our experience in the Philippines. So I'm Imogen. Most people I think will know me. I'm from the West Midlands team, and 2024 in February, myself and my colleague Louise Kafaki went to the Philippines with Khurram Khan. He'd previously been out there before and built links, and his name's going to be completely out of my head now. Andrew
Hodges.
Hodges,
yeah.
has done a lot of work out there. He was unfortunately not able. The plan was he was going to go out there as well, but the plan was that he couldn't make it out there. But he'd worked out there and worked with some speech therapists and felt that they needed some support out there. So I'll just share my screen if I can.
It's a different sort of model of partnership, Imogen, isn't it? This is you joining and otherwise established.
They are established. They are funded. The therapists are funded by Smile Train, I believe, or operate. Yeah, Smile Train. So they work under. They work under quite strict rules. So it was tricky in some respects because they have to obviously complete certain protocols. And they'd had a lot of training, the two girls that were working out there, Rika and Rafi, had an immense amount of training. So they'd been funded to attend lots of training courses in cleft and various things, but they were both quite newly qualified. Although out there, I think 3 years is considered very qualified in terms of speech therapy, but they were both newly qualified. So they didn't have a vast amount of actual practical experience, which was quite obvious when we got out there, really. Can everybody see the screen?
Yes.
Can indeed.
Yep.
It's great. We can see your.
Okay, so just a little bit of overview of the Philippines as a place itself. People probably know this, but it's a huge area made up of lots of islands, 7,600. So it's very diverse in its population, and there's a lot of languages spoken. But in my experience, when I went out to Vietnam, the language was a big barrier for us. Out in Vietnam, we were working out there, but in the Philippines, a lot of the families that we saw were able to communicate in English, so that was a positive. I know it has its own socio-economic challenges that is seen in many other countries that we travel to, and the lack of ability to get to the centre, even though they have this unit that's established. Is tricky. So they do see a lot of the wealthier families can get to the centre, and the other families have been treated out in their rural areas by missions. So a Smile Train, Operation Smile, but the palette hasn't been touched or looked at, and they've been left with quite severe, significant speech problems. So we went to the Cleft Centre at Thibaut Hospital. It's a Cure. The Cure is a charity, and so it's a Cure hospital out there. So we were volunteering with Cure, and they're the areas that the Davao region. So as you can see, Davao right at the bottom of the map. It's a big city. But it serves the hospital serves quite a large area over in the Mindanao area and wider areas. So a lot of patients are brought in from quite rural areas. Before we went on the trip, because we knew that these therapists, the speech therapists, had got experience. They were working in a cleft centre. They were working with surgeons. They'd worked with Andrew Hodges. And we knew where Andrew felt there was a need for some support and training. So, but we wanted to meet them. So we did a lot of scoping. We did some Teams meetings before we went out with them. We did lots of email contact. We talked about what they felt their needs were, how they were set up. We had a lot of information before we went out, so we were quite prepared with what to do out there and the plans. And we discussed with them what they would like us to do and how they could prepare for that before we came out, to try and make the most of our time out there. So during the actual visit when we were there, Rafi and Rika had booked in their most complex patients. They're patients that they'd been struggling with, that they didn't know where to go with, that there were, or patients that were continually coming back because they were delivering therapy to some patients, and then others it was an assessment service. When we were out there, we realized there were very few protocols or processes. They didn't have any procedures they were following or any criteria. So they were just kind of taking everybody on and continuing to see everybody, whoever turned up on the doorstep, really. So we demonstrated a lot of assessment, a lot of hands-on stimulability and therapy. We talked a lot about training, very specific training for them to develop their skills in terms of all the things that we would do, and the activities we would try, and the assessment protocols we would follow. They loved the mirror. They'd never used the mirror before, so they thought that was awesome. We did a lot of explanation and very specific work on speech therapy out there. Cleft had given us some money to fund some toys and take toys out there, so we did that, and they loved that. They have got quite a lot. They have got a lot of resource out there. Interestingly, they have a little therapy room, and do have a fair amount of resource. But these were new things, and the children absolutely loved them, I have to say. So we did a lot of hands-on work when we were there, in terms of training them to be able to continue when we weren't there. And we demonstrated a lot of it. You can see in the top corner that I was doing, there were two sister twins. So I was doing some therapy with the twins, which they were a bit amazed about, actually seeing two children at once. So we talked about how, how you can increase your numbers and get through your numbers. They started to do, Rafi and Rika, you can see in these pictures, were starting to do some of their own work. And then eventually they were just carrying it out, and we were observing and advising them in the kind of work they could do. Very quickly, it was time to say goodbye. What we also covered while we were there, in terms of just hands-on training for them, we did a lot of I went through quite a lot of service provision and protocol work, and we looked at all the different pathways that the children could follow, and if they presented in one way, they had they weren't discharging any of these children, and they were hanging on to children where therapy was not going to be viable or successful, and bringing them back. And so we talked through where they put their resources and where they channel their resources, because there are two of them. They literally, I think they're 2 days each in the hospital, and it covers a massive area. So they've got very, very little time out there to see these patients and manage the service. So we talked about kind of doing a bit of a needs analysis, and looking at their demand and capacity, and being a bit stricter with who they were seeing. But they were brilliant. We had a great week. It was so welcoming, and we did a lot of work with the MDT. They also needed quite a lot of MDT connection. They worked very separately from their surgeons. Although they were a team, an established team, they didn't really do very much together. So we kind of tried to encourage that and talk about how we would work things in our centre. And we left after, I think we were there for a total of 11 days, but it wasn't actually the end of it. It was a real beginning, as it's turned out to be. So over the last year, we've continued our support, we've continued our mentoring. I've continued to support them in service challenges, and talk through with them how they can manage their caseload. We've tried to build some resilience, actually, and start to look at training other therapists across the region and wider, in terms of doing that online, and setting up we tried to do it when we were out there, and it was difficult because it was short notice, and we couldn't get the uptake. But therapists were really keen. Speech therapists that work out in the community were really, really keen. So we're trying to set that up so that we can do some training. Rika has actually left now because she got married, and she has moved, I think, to Japan, and which does happen. Rafi is still there, but what we want to do is train them to be able to train other people, and they're really keen to do that. and we would like, that's why we want to get other people, other therapists involved, train them up to build that infrastructure and resilience really in the team, so that we have that contact. We can work with anybody new there, and Rafi can train anybody new. She has those skills now to do that, and so on. They've participated in quite a lot of our provision in Birmingham. So our early parent workshops, they've attended some of those. They've come to our links, speech therapy days for additional training, and also they've delivered presentations on those. We've discussed different research projects. They have and they've attended our student training as well. So they're part of all of that. And our future directions I've talked about is to continue with that, to try and build the wider resilience. Hopefully, we would like to do another visit out there. We would like to go out with a restorative dentist who can help us with the more complex cases, and looking at obturators, nasal obturators, and how we can provide that. We're continuing with the mentoring. We're in contact with them every month, and we look at complex cases, service delivery challenges, and also research projects. And there are acknowledgements to everybody that sent us out there.
Wonderful. Well, thank you very much, Imogen. That's another very exciting, completely different project from and Link. And I'm very excited, but that we were able to partner with that group, and it seems to have legs, and there's a lot of development and good partnership. I know your time limited, and and we have a lot of speech and language input people online. I don't want it to be a whole discussion about that, but if before you go, if there's anything before I hand over to, I want to bring Kate in, and then Dr. Rai from Nepal to go back to that project. But is there anything anybody would like to particularly ask Imogen for clarification? I was immensely encouraged by the development of that link, and I think there are probably very many, I would like to say more than scores of units around the world who would probably benefit from some of the gaps that are missing. As you say, there's a lot of primary surgery going on, but not a lot of all the MDT type work that I think we have a lot of strengths to Okay.
I think Marie had a question.
Oh, Marie, I can't, sorry, I couldn't see. Yeah, Marie, fire away.
Hi, Imogen, thank you so much. Fascinating and really rich information there, and lots for us to think about in Bangladesh as well. I just wanted this sort of marriage between Smile Train and who are really the employers of the two SLTs. Was there any friction or a rub, or was it did it just become a natural marriage, do you think?
There wasn't really. I mean, they went through, they showed us all the aspects of delivery that the boxes they had to tick, really. And some of it is quite different from how we would assess and do, but we adapted around it. And Rika and Rafi were absolutely brilliant. They were really flexible, and they didn't, as long as they ticked these boxes in terms of seeing a patient and sending it off. It's data, it's numbers. Sadly, was what I felt for Smile Train. It was not really. So they were just sending off numbers and data, but there wasn't really a holistic view of it. We talked about the sparkle, we talked about quality of life, we talked about the actual practical, what you do with these families when they're sat in front of you. And these girls are there and they're doing a lot of kind of psychological work, a lot of support that a psychologist would do. They don't have a dentist, they don't have an orthodontist, so they are lacking, and they take on a lot of the role of that. And I think, so I don't think the Smile Train, Operation Smile, any of those are particularly involved once they're out there. I think they give them the training that they think is enough, and then they send them out there. And these girls have their own private companies as well, and they have private therapy because they can't survive on the money they get. to work in the Cleft Centre. It's not a lot of money that they're given to do it, but they love doing it, and it's their job. So they will work all hours into the night and have their own sort of online businesses and private businesses, as well as running this Cleft Centre, which they do exceptionally well, considering they don't have that experience, because they are managing a service as well as delivering the goods.
Imogen, thank you for that. We could probably have a very long discussion about the relationships with Smile Train and OpSmile, but I'm not going to go down that avenue any further, if that's all right.
That's okay.
I'm going to just have one more question to you from Jane Kirby. Jane, would you like to? We sort of had a brief glimpse of you on screen.
Yeah, sorry, I was just checking my camera was working.
Have a quick question. We'll move on.
Hi, sorry, I'm Jane. I'm one of the cleft surgeons in Newcastle, working with David. Imogen, thanks for that talk. That was fantastic. I was just wondering, you mentioned one of the speech and language therapists has left the Philippines after lots of training. I've been to the Philippines for the past 2 years with an Australian charity, and we've talked to them about, teaching either with cleft nurses or speech and language therapists. And their main concern was that if we did train them up, that they would then leave the country. And I was just wondering whether yourself or anyone else on the panel had any advice on whether there is any way to deal with this. I think ultimately they probably just need to be paid more, and that's probably the answer in order to keep them. But is there any other advice that anyone else has with regards to trying to keep people once they've been trained?
We talked a lot about this on Saturday at the away day. I think it's really, really difficult. I think we want to maintain the links with that unit and then even look at other units, because I think we need to get into in terms of speech therapy, the speech therapy infrastructure over there, really. That's the only way of doing it, is to train the trainers, really, to train the speech therapists to be able to support the therapists over there and get them involved. And there was a lot of uptake in that. The only way you'll get resilience is to train the speech therapy community or the other communities of professionals out there, which is a bit of a drip approach. But I think you have to maintain that link on a regular basis when you're back in your country to be able to do that. Otherwise it just gets forgotten and they just carry on as they are. So I think that's a really difficult one. I don't know if Tim or anybody else has any points. It's a challenge.
Well, I was wondering that it's a massive question about the health economics of disparity between healthcare systems and what it has in a global context. And good, thank you for raising that, Jane. It's a big subject. I think we could probably spend the whole of the rest of the webinar talking about that. But I think what might be a good idea now is if we can bring in Dr. Rai from Nepal. He might have some comments. I am aware how late it is for him, and I'd like to bring him in. So coming back to the Nepal network, and you have a lot of experience of different teams and funding mechanisms, Dr. Rai, and then I'm going to also introduce afterwards Kate, who has travelled with the Newcastle team, and we'll talk a little bit more about psychology and psychological input. But would you like to come in and tell us your thoughts?
Yes, sir. Thank you, sir. We are very glad to have the Cleft team in Nepal, and then all the people in our department have been benefited by the education and training that our team members have been receiving. We particularly appreciate the EMDT concept. Of course, we're trying to involve few of them, but it is not at the same level like you do in the UK. The involvement of the psychologist in your team was very educational for us. In fact, we had one psychologist in the whole hospital, and then he was always involved with the burn patients, especially because there are so many burn patients. That's true. But at the same time, there are a lot of, suicidal, homicidal, and few other, complex kind of situation with the burn injury patients. Whereas we were not paying much attention to the psychological aspect of the cleft care. Of course, we had many patients who had several, stories. For example, children being deserted by their parents and taken care of by some other people. parents discarding their children with cleft, and then the grandparents are taking care of them, things like that. There are a lot of other things. And there was one incident I remember. A father committed suicide because he was working in India and he came to Nepal. On the way home, somebody told him that the newborn child is very disfigured, almost to the level of demon. So he could not go home and see the child. Rather, he jumped onto the river and killed himself. Things like that. There are so many incidents, but we had never paid attention to the role of a psychologist in our cleft team, and that was a very big eye-opening lesson for us. And please continue to send the multidisciplinary team to us so that it gets reinforced in our mindset of the cleft care in Nepal. We also very much appreciate the support to our cleft fellow. In fact, there came another cleft fellow sent by a private medical college. The funding is done by the private medical college itself. They want to develop that service in their medical school from the far west. And that was very good. So now we have two fellows. One is supported by you, and then another one supported by a private medical college. Hoping that this private medical college will establish that cleft team there. We'll have to support them. Maybe in the future, some of you will also visit that place, and then we'll support them to start the cleft care there also. I also really, really appreciate what you have been bringing in. Not only just the equipments and other supplies, but also the goods for the children, to play with. Of course, those are simple things for us now, but I think again, now we understand how important it is for them to play with, especially with the speech therapy teams. We really appreciate that. And one thing I would like to mention is the cases, most of the surgical operations are performed with the help from Operation Smile Train, but the Smile Train requires to have either fluoroscopy or nasoendoscopy before we can do the vilopharyngeal repair for the BPI problem. And we obviously have not been able to do any of those. And then, of course, but we diagnose the case clinically because they have this hypernasality. There is a big gap between the soft palate and the posterior pharyngeal wall. The soft palate is very short. Sometimes the soft palate doesn't even move at all. So we'll have to do something. We do those operations, but those are not covered by Smile Train because we do not have the diagnostic procedure that we do. But probably, I think that's an area where you can teach our team members how to do that, and maybe also provide some sort of second-hand or third-hand kind of nasoendoscope from one of your hospitals, maybe just like you did with the articulator. That would be really, really helpful for us because that will be another step for us. Then the other thing is already mentioned a little bit, that is about the help we need in training our team in the secondary cleft. It's not that we do not do secondary cleft. We have been doing some, but I think our expertise is not at that level that we can say, okay, we are comfortable with the secondary cleft, especially with the big fistulas and so many different kinds of BPI correction. The orthognathic surgeries, I think that'll be the third step, I would say. First step, there's first or second step is, I think, to be able to be to do the secondary clefts of all varieties comfortably. at a reasonably reasonable level, I would say, not at your level, obviously, but at a reasonable level of the expertise. That is what we are trying to get from you.
Thank you.
And I hope you'll be supporting our nursing education in the future also. That is also very kind of you. Thank you.
Dr. Rai, thank you. That's a wonderfully encouraging sort of collection. If I had to put you on the spot, this would be very countercultural, but to say, is there something that teams, not just us, but teams can get wrong? If there was one thing that you would like to correct with when people or advise people not to do or to do differently when they visit you?
No. I don't think there is anything like that. But you are very sensitive culturally, and there are very few teams which are so sensitive about the cultural things. So we really appreciate that.
Okay.
One more suggestion I could make probably is involving younger people also, because the way I see is when we involve very young people, then these are the people who will carry on our torch in the future, because they need to be trained. If you bring in those people in Nepal, then they will continue to come probably. If they think that it's reasonable thing for them to do to continue in the future, and then those people will be the leaders in the future when all of us are retired. I hope I make you understand what I'm trying to say. I'm always looking at the future. That is very important. There was a time when I used to think that they should not bring any young people because they are going to get all that attention, and then they will not be paying attention to my training. That is what I used to think. I'm talking about 35 years ago. But now my vision is a little different. I think we have to involve the young people also, so that they will be continuing the work after all of us are retired.
I think we're in much more harmony with your thinking on that than you anticipate. We're all thinking about the future and the young. So thank you. That's a really important matter. I did want to, perhaps at some point, we might just address the subject of how we retain staff, because I think that's a big matter. And perhaps I think possibly having team partnerships is something that building a good team and team relationships will help to retain your staff and so forth, and bring in new ones. So you very kindly, you were very positive about the psychology side of things. And can I bring Kate into this now? You've met Kate on the visit, and
yes.
Let's see if Kate has a contribution to make. Thank you, Kate.
Yeah. Let me try and share my screen. Hang on. There we go.
Well done. It's coming up. Yeah, there we go.
Try not to show you all my slides, or try not to spend too long either. So that's me, obviously, Kate. So yes, I mean, I feel like I'm not sure if I feel like I'm fully entitled to be here. My experience of global cleft care is reasonably limited. My time with the group, largely based in Newcastle, going out to Nepal, I've been out twice now, is probably the extent of my overseas work or input. And I know Shankar and the team in Nepal have been very accepting of, appreciative of, supportive of kind of the role of the whole MDT, and I think that really comes across. And I think that's probably one of my biggest take homes. I joined a circle of cleft professionals meeting last week, and the focus on MDT care globally is something I've really been struck by recently. But for what it's worth, I'll sort of share a little bit about my experience. If I can do that. So hopefully most people here know I won't go over what psychologists do in UK cleft teams, but I put that there because obviously I know what a psychologist does here in the UK. But before I went to Nepal, when I first got involved, I was quite anxious about the idea of going overseas to a low or middle income country with my sort of Western views of what psychology and psychological well-being is, and what a psychologist offers, knowing how we offer it here, but not being sure how that would go down, be received, how appropriate it would be, and being a little bit anxious about some of the extra factors that I knew could be at play overseas. So some of these sorts of factors, social factors, demographic factors, cultural factors, which made me sort of anxious about how useful I would be, I suppose, not wanting to be a resource or somebody going along on a trip and not being able to offer anything helpful, maybe not as useful as some of the other disciplines. But actually, so I'm sure everybody's familiar with Maslow's hierarchy of needs. I sort of looked at this model and thought about the needs that people have and where psychology fits in, and psychological well-being fits in that pyramid. So, you know, physiological needs, safety needs at the kind of the bottom of the pyramid, and thinking about what people need in terms of just basic health and physical well-being. I know in some countries and some settings, you know, even managing to meet those needs, you know, is primary. And so I guess the sort of psychological needs come much higher up that pyramid. And so I wasn't sure how much space, capacity, option there would be for that. In reality, what I found in Nepal was that the Nepali team, and I'm sure it's the same across other centres, I know Imogen talked about the Philippines, is that actually psychological well-being is a universal concept. It's something that teams are all very aware of and are all working on. And, you know, Shankar said there that, you know, the team hadn't had psychology input before, but my experience of meeting the Nepali team was that they're very psychologically aware and that people are providing psychological input, maybe just not directly through a clinical psychologist in the team, but the team are incredibly aware and thinking about their patients and their staff's psychological well-being. So, and as David's already said, in the Nepali team, certainly it is the peripheral nurses who are acting as the team psychologists, like Imogen was talking about in the Philippines. This team of nurses are incredible, and they are providing dental health advice, certainly doing an awful lot of speech therapy work. They're preparing families for surgeries. They're there right from the point of a baby being born with a cleft. And they are very much delivering a psychological approach to families too. And so in my time with the Nepali team, we spent a lot of time thinking about what psychological well-being means, what it means to them, what it means in their culture and in their context, thinking about how cleft affects individuals in Nepal, thinking about how all of us and everybody in whatever team they are in, whatever country or culture that they're in, can offer kind of input that's psychological. That doesn't have to be formal therapy as such, but the team there are doing an incredible job already, and we're really engaged with the idea of how to offer more psychological input, psychological first aid, and thinking about the different ways in which you can deliver psychology, if you like, without having a psychologist, without offering therapy. So thinking about providing information, about providing support, about connecting, about peer support, about connecting individuals and families, about drawing on the resources that they already have and enhancing people's experience and improving their quality of life. So, I mean, I'm very happy to answer the questions and chat about this some more, but my experience of going out twice now is that the team are very psychologically aware, very keen to learn how all of them, nurses, surgeons, dentists, can enhance the psychological experience of the patients and the family and also the staff team. And I'm along with Siobhan, who's done an awful lot of work with that team over the years and has a very good and ongoing relationship with them. It's been a real pleasure to kind of partner with that team, and hopefully we're going to continue to have a relationship, continue to work with the nurses. We're thinking about some ongoing sort of audit and research and developing some of these information packs and so on going forward. David's already shown that picture. So that's a very tiny insight into kind of my anxieties before I went, and then incredible work the team do and the privilege it's been to work with them.
Thank you very much. That's very helpful, Kate, and a good overview. And I again, we could probably have a long discussion about the role. We could have a whole webinar on the role of clinical psychology in a cross-cultural global context. So thank you for opening that up. I'm aware, lots of clapped hands there for that. Thank you, Siobhan. If you can, I cannot necessarily bring you in now because what I'm aware of, we sort of advertise this as being taking roughly an hour. I don't want to prolong this too much for Dr. Rye in particular. I want to give you the opportunity to leave. And we are going to move to a much more experienced, longer term team involvement with the Bangladesh team. And Brian and Marie and Chloe are going to just give us something of an overview of their engagement and what they've learned. And I think perhaps if you can, you might want to just put any questions in the chat if you've got a sort of short question, and do feel free. I'm sorry if we do need to give everybody space to leave when they can or when they need to, but if you can hang on for the next 15 minutes or so, or 20 minutes until 15:15, that would be great, and we can have more questions at the end for any who would still like to chat. So Brian, can I hand over to you now?
Yes, thank you, Tim, and thank you to all the previous speakers. There is a link between Bangladesh and Nepal. I met Shankar in Dhaka. When was it, Shankar? When were you there?
2008, 7, 8, somewhere 8, 9, somewhere there, I guess.
So Shankar, because there was no plastic surgery accreditation training in Nepal, did his plastic surgery training. Although he was already a very experienced plastic surgeon, he did his training in Bangladesh. And Shankar, as you will know, and I'd be interested in your comments about cleft care in Bangladesh in 2007-8, but Bangladesh is a long way behind what you've achieved in Nepal. If I could just share my screen.
You're on. Thank you, Brian.
So thank you. A brief history of the project that we've had with the North Thames Cleft Centre, but even before then. So Bangladesh, 180 million people, rather a neglected country, I feel, compared with the publicity that many countries get. So my personal experience there began in 2003, and it was really surgery only. Many unoperated clefts, many badly operated clefts, many complex craniofacial, complex facial clefts, and really no multidisciplinary care at all in those early years. And then gradually, after many annual visits, we began the real cleft link with the North Thames team, running annual workshops. This is 2013. You'll see Marie there, and Bridge Patel, and Jonathan Brito, and Emily Anderson, one of our recent cleft trustees, giving a talk at that MDT. And then in 2016, we had the opportunity to help the Bangladeshi team actually establish a cleft centre. And it really was the first such centre in Bangladesh. So we set up a ward. We established an operating theatre. You can see two tables, and appointed the first cleft speech and language therapist, funded by Cleft. This was in a hospital where a few cleft procedures were carried out, but with absolutely no multidisciplinary care. And this was the main number one teaching hospital in Bangladesh, Dhaka Medical College Hospital. Having established that clinic, and with the support of the then Prime Minister, a new building was built. So the 100-bedded burns and plastic surgery unit became a 500-bedded burns and plastic surgery unit, and that's it in the distance. But because we'd helped establish the centre in the previous building, it was established. It was continued in the new building, and there's the cleft floor at the top right hand of the screen, in which there are 2 orthodontic rooms, a speech therapy room, an audiology room, a clinic room, and so on. In July 2024, Sheikh Hasina got wiped off the name of the building because there was a revolution, which I'll come back to. So that's a little about surgery. Marie, a little about speech and language therapy.
Brilliant. Thanks, Brian. Can everyone hear me? Yep,
Yes.
I can't see anybody. Thank you. So we've had some successes and some challenges, and I think we've tried to be balanced here in what works well. One of the great successes has been the link that we've had with the Department of Communication at Dhaka University, and that was really from us developing the MOU. We've talked to all the speech therapy students there, and there is a natural linkage. And Tawhida, who is the head of the department, the clinical lead for the Department of Communication, has really been involved at every step of the way. So that has, I think, made a significant difference to our experience in Bangladesh. Interestingly, staff recruitment has been challenging at times, but again, we've been able to link into some of the master's students who have been qualified, and then some of the wider professional SLT body, we've accessed them as well in order to recruit. So that has also worked with this linkage to the university. They also have their own professional body, so they are a speech and language therapy recognised profession in Bangladesh, which I think has helped us as well. And with that relationship with the university has also enabled us to develop some research. So the master's students have recently been involved in the reliability and the validation of our Bangla speech assessment that we're trying to move forward. And ultimately, with the clinical team, the development of the assessment tool, which we hope to lead to publication in due course. So it's been education, it's been research, it's been the university working alongside the clinical team, but also the clinical lead also working with Papon, who's the surgeon who's leading the service there. They work very closely together, and I think that has been a great benefit to us. Next slide, please, Brian. And then the challenges, well, establishing an SLT service within a large hospital where there were no speech and language therapists at all, a large plastic surgery unit. Burns was really the main clinical load, and accepting that would be the priority, of course, but also that we were trying to establish a speech and language therapy service within the context of a large surgical led team. So that took some negotiations, and really the success of that led to Papon, who was really seeing the benefit of us coming into his service. We also tried to set up some protocols and treatment pathways, but that's very difficult within the context of follow-up and just the geographical area that we're covering. So that continues to be a challenge. And of course, MDT working when it's primarily surgical led and you're bringing in an AHP to work within that adds a different dynamic and a pressure as well. And interestingly, staff retention has been quite a challenge, and keeping those that we have trained, both within the department and also within the country, has been difficult. So both speech and language therapists who we've two speech and language therapists that we've trained have now gone abroad. One to do their PhD, and the other to work outside within other countries as well. But also educating that we need to report our outcomes. And this is a new piece of work that we're trying to do in order to help them understand the need to reporting that what you do has benefit and impact. So we're starting tentatively to talk about speech outcomes and pre and post follow-up, etc. But we have to be mindful of the context in which they're working, where follow-up will be very difficult to achieve. So thinking creatively and differently in how we can do that is one of our key drivers. I will hand over to Chloe, who will now talk you through from the orthodontic perspective.
So I'm fairly new compared to everyone in terms of the team in Bangladesh. So I joined 2 years ago, and prior to this, Dr. Brij Patel essentially was leading on the orthodontic UK side. So part of the successes really is the centre has 2 part-time orthodontists, so covering 3 days a week, which is, I think, better than the 1 part-time orthodontist who's been around for a very long time. Essentially, the orthodontists from the kind of dentistry side, they're the only dentists there, are pretty much superheroes. They make their own appliances that they manufacture on site, manage all of the primary care really and primary disease, as well as the hygiene. So I think recently, at least, we've noticed some improvement in oral hygiene. It's difficult to say whether it's just in preparation for surgery or kind of a long-term change for those patients. But obviously we've tried to push the message of oral health kits, oral hygiene, distributing some fluoridated toothpaste. But a lot of the population is illiterate, so even translating some of the leaflets has had some limited success. I think in the time that I've been involved, I've noticed that the orthodontists are really meticulous in preparing patients for surgery, establishing records. I think that's something that's been really drummed in and that they do excellently. And both of them are very interested in research and audit of their population. And I guess the slight thing is, now that more secondary surgeries are being planned and undertaken, particularly bone grafting, the orthodontists don't have to be as heroic in trying to manage all of the really severe skeletal discrepancies. I think for a long time, when patients weren't able to have operations, essentially the orthodontists were trying purely on their end to solve all of the dental problems, including really quite severe malocclusions, which I'd say, at least in my centre, I wouldn't try and manage. Next, please. Some of the challenges, obviously, is oral hygiene is not necessarily a priority for everyone. There's a very wide area that's covered and lots of deprivation. And there seems to have been some conflicting messages in terms of public health. I think a lot of dissuasion of the use of fluoride, particularly in children. And naturally, I think a lot of people have a very high sugar diet, particularly as that is a fairly affordable option. So that causes a lot of primary disease. There's no support from pediatric or restorative dentistry, which really means that the orthodontist time is a lot of the time used up doing those types of kind of interventions. Because the centre is based in a plastic surgery unit, there is no involvement at all from oral and maxillofacial surgery, which is a little bit challenging when we're considering operations that involve teeth, and particularly since they're quite keen to learn about osteotomies. But there's a lot of political influence behind that, and maxillofacial surgeons in Bangladesh are densely trained, and there seems to be a sort of reluctance to involve them in the centre. So the team I think, has become fairly good at doing bone grafting, but I think the new interest is to learn about osteotomies. although the majority of the population hasn't had bone grafts yet. So there's been a bit of back and forth in terms of trying to establish what the priorities are. There's a lot of hierarchy within the hospital, so I think the orthodontists don't have much of a voice in the MTT sometimes. And there seems to be really slow progress of cases overall, essentially trying to prioritize some of the primary surgeries, which is fair enough, but some of our older patients who've missed the ideal window are essentially waiting indefinitely. That's it.
So just to finish off, we have, with our colleagues in Dhaka, we have helped them to create the first comprehensive cleft center in Bangladesh. And that depends a lot on the leader, and that's Papon on the right there, picking someone who is sufficiently altruistic to make this his great project, and someone who can work with other team members. So, and this concept of a team in Bangladesh has taken a long time to develop. The idea of a team of equals, which really among the surgical fraternity is just a totally new concept. Very impressive is how they've kept working, and since the revolution in Bangladesh in July last year, they kept working. Their output didn't change. Very impressive that they've kept going. So some of the challenges, just two of the challenges. Politics, not just the effect on the country of this revolution in July. You may know 1,500 students were killed during that revolution. So it obviously affected the country and is still doing so, to the extent that we cancelled a team visit in February. But also, politics seeps into the hospital. As soon as there was a change, as soon as that government, the Awami League government, left, those in the hospital who'd been very big Awami League members were shifted, and members of the other parties were shifted in. And so it's a very politically weighted country. And I just want to say one thing about Smile Train and other NGOs. They have undoubtedly done a great deal of good, in that they've facilitated operations on many who would not have otherwise been operated on. Smile Train probably is probably responsible for 95% of cleft operations in Bangladesh. And that has two very bad side effects. One is it means that the government can abdicate its responsibility and just rely on NGOs. And the other very bad effect is that the Smile Train model of funding surgeons to operate in private hospitals, or funding private hospitals, means that if you're a surgeon working in a government hospital in the morning, you have no desire to operate on cleft patients in that government hospital, when you can go in the afternoon to earn a significant amount of money operating on as many patients as you can in a private hospital. And that's why someone like Papon, who is able to see beyond that, has been so valuable. But some of those Smile Train funded surgeons have actually worked against what we've been trying to do in that hospital. The future, more comprehensive centres in other parts of the country. We have already begun so in Mymensingh up here. We hope that in time the government will take over what we've been doing in that government hospital. And we hope that what we're producing will be self-sufficient in the future. Thanks very much.
Brian, thank you, Chloe and Marie. That's a fascinating long-term story and lots of challenges. Excellent to learn from it. And I must say I've been impressed thinking about all these presentations about how much there is to learn for each of us, and how much, if we can document with good research, there's a great journey to learn from and to talk about. We got to 1:15. I would love to have some questions from anybody about there are a whole ton of topics which have been brought up. I don't know whether Richard, as an outsider, has any thoughts about how, as he's seen the diversity of some of the activity that Cleft's been involved with, or questions, or does anybody have any immediate comments or thoughts that they'd like to flag up? Jane brought up the subject of health economics before, but is there anyone wanting to open up at all? I was very impressed about how, Brian, you want to come in?
I'd like to ask Shankar. I've been in touch with Shankar about him coming to Bangladesh to share his experiences in what he's created in Kathmandu with Dhaka. But I think the idea of links between different centers in low and middle income countries has great potential. I'd like Shankar's view.
I think that's a very good idea, sir, because I not only in the cleft, but I also see that kind of collaboration needed, cooperation needed in other fields of plastics, especially burn care as well, because as a global South, we all lack the expertise and also the resources. And there is always something that we can help each other as well. I mean, of course, we need help from the north, but at the same time, there are several things we can help each other at the global south level as well. So I would be more than happy to go there and then maybe invite some of the Bangladeshi colleagues like Papon. You can come and see how we do it. But from the story that you have told, I think they have done a lot from the stage where I had seen them when you were struggling to develop that to the present situation. I think it's a big change. I think I remember bringing a team of surgeons and some other fellows also to Kathmandu to show them how we organize the speech therapy, especially training these speech assistants like the nurses and others. And of course, Siobhan and her friends have been very instrumental in developing the cleft speech program. And then another strength I think that we have is the involvement of the maxillofacial surgeons. As you saw, 3 of our cleft surgeons in our plastic surgery team are all ladies, and they're all from the maxillofacial background, and they are the best cleft surgeons in our team as well as in our country, I think. So I think we should involve the other specialties also. I mean, rather than keeping it only within plastic surgery, profession. It's the question of delivering the best service that we can to our people. So it doesn't matter who does it. As long as they are trained adequately. But I think you forgot that I followed you to many different countries actually to learn your technique. Of course, I tried my best. I visited you in the UK. You took me around, and then when I came back, I thought that was not enough. I have to learn more from you and from your technique. So I started researching who had learned from you from this part of the world, who were the surgeons who had been trained with you. So then I knew that there was somebody in Sri Lanka who trained with you in Great Ormond Street, London. And then I went there, and then I worked with the surgeon that you had trained. And then I came to know that you were coming there. So I went back again. And that was the day when tsunami came, if you remember that. And then I started following you to Bangladesh also several times. Yes. And I really appreciate the involvement of your team members like Siobhan right from the beginning of our program. And then I was lucky that David thought of Nepal because of his past experience in Nepal to be one of the partners of Cleft. I really appreciate both of them, David and Siobhan. Thank you.
Thank you, Dr. Rai. That's a wonderful sort of summary of your of where you stand now and where with the team. Without Siobhan's been patiently sort of listening in, and I'd like to offer you an opportunity to say anything, Siobhan, if you like. But also, I did mention Richard Carrick as our new trustee with a very phenomenal marketing background, and whether, Richard, you've just seen a snapshot of Cleft involvement in diverse places, and whether you had any comments, Richard.
Yes, indeed. So I've been busy. I've been sat here taking notes, and I specifically wanted to listen in to this webinar because I wanted to get a much more detailed understanding of what we do and the way that we do it and where we do it. And I'm looking at it also from the perspective, and I think particularly from the perspective of potential corporate funding, and to what extent we can offer corporate investors or potential corporate investors a sponsorship or a partnership opportunity that might be by geography, depending on where that company operates, where it has outlets, where it has employees, what it does, or could it be a research topic, or could it be by one of the specialist areas of the multidisciplinary team? So, and I think if you can present something that is relevant to a corporate sponsor in that way, based on what I've learned tonight, and bearing in mind that this is still very much work in progress, I think we stand a better chance of engaging corporates to support our work rather than looking for one big dollop of investment that is non-specific, if that makes sense. So the purpose of me listening in my infancy as a trustee was to learn more about what we do and how we do it. And certainly some very impressive presentations, yeah, so very well worthwhile.
That's lovely. Thank you, Richard. That's very, very positive, and something for us to really take away and look at packaging up specific topics like that from a marketing perspective. Yeah, that's great. In our last few moments, Siobhan, David, anything you'd like to put in to add to the comments we've had about Nepal, or your long experience, particularly Siobhan, with you've been at this for a long time. Along with Brian and others.
Hi, thank you. I didn't really have anything planned to say, but I suppose one of the things that hasn't perhaps been mentioned much tonight is that we bring back a lot of expertise from Nepal. So, I work in the northwest of England. I see an awful lot of children who speak Asian language as their first language. And I think that experience of working with the team in Nepal helps me to manage those children in the UK in a much better way than I would have done if I hadn't had that experience and that drive to kind of understand some of the Asian languages and the specific effects on speech. That it doesn't just help my ability to do things in Nepal. It helps me doing things in the UK as well. And I think that's a benefit to us and the community here that might sometimes get forgotten.
Thank you for reminding us that, actually, Siobhan. That's absolutely, I couldn't agree more, actually. It's nothing but a privilege. I think all of us who've had long-term overseas links, it's been nothing but a benefit and an enriching thing for us and our teams and community to have that involvement over the years. I'm just aware we haven't had any comment from over what I would call over this small bit of water, not the big pond, but the small pond from Trina. I don't know whether you've got any comments, Trina, from.
Yeah, it was funny. I was just thinking about Siobhan, because I know, Siobhan, you were in Nepal for a long time, and I think you were probably going there before because you were officially twinned with Cleft. And I'm just thinking the last 2 times you were there under the Cleft Bridge and the Gap umbrella, and what stood out for you as the difference between when you were going kind of in the earlier days in probably a less structured way compared to going now? What stood out for you?
I think there's been an awful lot of changes. They've now got a hospital, a Cleft and Burn Centre, whereas in the past we were working in various different hospitals, different organisations, and I think there's very definitely a whole team that's come together in a way that is more similar to an MDT team that we would have here than it was in the very early days. There've been an awful lot of changes, a lot more emphasis on speech and a lot more understanding of what some of these children need, and some really innovative ways of trying to meet the needs of children who live in a very diverse communities a long way away from the centre. And some of the outreach stuff that we haven't really had a chance to talk about tonight, but some of the outreach activities that are going on are really impressive.
Yeah.
Great.
Okay.
Thank you, Tim.
I noticed you just popped up on screen, but was there anything you wanted to contribute at all? I was looking at Melanie Bowden, but yeah, no, it's just, I wonder whether you wanted to say something.
It's just all very impressive, to be honest. And I know Siobhan has longer term aspirations to be working in Nepal, which I think is really commendable. So yeah, I look forward to hearing more about her experiences going forward. So yes, very proud of Siobhan for what she's was planning to do.
Well, we've been a very small group, but it's been helpful. I think a very enriching and helpful exchange this evening. It's a shame we haven't been able to. I don't know whether anything was recorded. We didn't. I think probably not, because we didn't sort of make an acknowledgement of that at the beginning. But there's lots to digest, I think, and everything from getting interested. I was really impressed how. One of the commonest things I'm asked is how do you begin to make a link, and it's David's serendipitous link almost in 14. He mentioned his elective right at the beginning, and all of us have these spontaneous. Serendipity is the only word I can think of where sometimes we develop links and partnerships, and it can then ultimately be enriching if we develop that in the future. So if anybody, unless there are any more immediate comments, I'll probably draw us all to a conclusion, and just mention, Brian put in the chat that the research webinar is on Tuesday the 22nd of April, just before the Craniofacial Conference. Another big plug for Newcastle for any. I'm sure all of you are on your way up there, but looking forward to that very much. I'm not sure how it's going to stick in the throat of a Southern football supporter to. Whether they'll come down off their high in Geordieland by the time we get there, I'm not sure. But with that, I think probably we'll draw this to a conclusion unless there's any more comments. Okay, but thanks one and all for giving us your time this evening.
Thank you, everyone.
Thanks, everyone.
Thanks, that was great.
Thanks, that was brilliant. Thank you.
Thank you. Thank you. Thank you, Ryan.
Thanks, Tim.
Thanks, David. That was super. That was a lovely introduction. What a great team you've got.